Welcome to Global Civics, a public affairs series about the rights and responsibilities of citizenship in the 21st century. Article 25 of the Universal Declaration of Human Rights proclaims that everyone has the right to a standard of living adequate for the health and well-being of individuals and their families. The International Covenant on Economic, Social, and Cultural Rights, an actual treaty, recognizes the right of everyone to the enjoyment of the highest attainable standard of physical and mental health. Does this mean that each and every one of us Americans has a right to health care? That's the question we'll be dealing with in this episode, and you will see and hear from a number of folks with different perspectives on the matter. We'll begin with a conversation with a pair of healthcare advocates with similar views but different roles to play in our community. Hello and welcome to Global Civics. Today our subject is based on a question: is healthcare a human right? And to help answer this devilishly simple, really complicated question, I have two special guests. Kate McIver, who's the director of the Lewis and Clark County City-County Cooperative Health Center.
Yep.
And Rachel Carol Rivas works at the Montana Human Rights Network. So I want to kind of start the conversation based on this question in a philosophical tone, and then we're going to talk in more detail about the work you're both doing in your respective arenas in the health care provision field and the health care advocacy field. So first off, Kate, what do you think? What's the simple answer to that complex question?
Well, in public health, we believe that everyone has the right to the highest attainable standard of physical and mental health. And we see that as making sure that the environment is clean, clean water, clean air, good sanitation, and we're working toward making sure that everyone has access to the same level of health care.
Yeah, actually, I love the way you just put that, because my reference point here is some international legal documents, the Universal Declaration of Human Rights in Article 25. I'm going to read it because it's fairly well stated. Everyone has the right to a standard of living adequate for the health and well-being of himself and his family. This is not gender-neutral language. It dates back to the 1940s. Including food, clothing, housing, and medical care, and necessary social services, and the right to security in the event of unemployment, sickness, disability, widowhood, old age, or lack of livelihood in circumstances beyond his control. There's a lot there. Then more cogently, in the International Covenant on Human Rights, which is a subsequent binding international law based on the Declaration, the states parties, meaning countries, to the present covenant recognize the right of everyone to the enjoyment of the highest attainable standard of physical and mental health. So you're dead on with respect to the requirements of a law that the United States has signed on to and has never ratified. So we're one of the scofflaws in the international community for that purpose. How about you? Rachel, how would you answer the question?
Oh, I think absolutely. For us at the Human Rights Network, sort of given our name, and although we focus specifically on Montana human rights issues, absolutely using an international frame that can bring us all together to talk about these really important things like economic justice, etc. I think that healthcare is by far one of those human rights that we should all have access to. And I think that when we talk about it in the way in which Kate's addressed, I think that people also are supportive of that idea.
Yeah, and before we get into more details about specific work that you're doing in this field, we can say that we have a right, and we can assert that and have a lot of people agree to it as a right. But what is the implication of making such a declaration? I have a right to health care. What does that mean to the rest of the people? What does it mean in terms of exercising or enforcing that right? I mean, in general terms, rights exist, but they require enforcement unless they're self-executing, and health care is not one of those things we can administer to ourselves beyond a certain step, or stage.
You have to recognize them and then enforce them, and I think that we find that part of our job as, you know, an education organization is to really talk about what it means to have human rights and what it means to have healthcare as a human right. So recognizing that as individuals and then as a collective, so having our state and our nation as government entities recognizing, as you said, we sort of signed on to some of these pieces of the Universal Declaration, and particularly this piece, but we have not chosen to ratify. And I think in a lot of ways, it's hard to have a conversation about implementing healthcare as a human right if we can't even just put it in writing out there that absolutely this is the case. So in a lot of ways for us, that's really the first step. That doesn't mean that we don't talk about specific policy in a framework of human rights still, but I think that we still have a very basic piece that we're missing, and that is to hear it, you know, sort of from the mouths of our officials and from each other.
Yeah.
And as I said, I think that in the United States, we believe that everyone has a right to clean air and clean water and good housing and sanitation in order to be healthy, and safe food as well. And I think that our government believes that people have a right to primary care, which is what federally qualified health centers like Cooperative Health Center provide, primary medical care, dental care, and some mental health care. But our country does not believe that everyone has a human right to specialty care, surgery, things like that. We have that as a specialty care, and surgeries are part of a private insurance system that excludes some people who either can't afford it or don't receive health insurance through their employment. You know, and if an American doesn't have health insurance, they are terrified to break a bone or get cancer or anything because they could possibly be bankrupted.
Yeah.
And you know, you mentioned Article 25 of the Universal Declaration, and that is sort of coupled with all the rest of the articles, of course, in the Universal Declaration. And one of those, Article 23 being sort of our right to economic security, and all grouped in our economic human rights. And I think that healthcare is intimately tied with our economic security and about economic justice. And we can talk about it as a moral conversation rather than just a who's to blame or individualized thing. Because so many people are at great risk of economic instability and devastation as a result of some major illness or injury. So I think those really fit together because that's the fear. I mean, the fear is your life and sort of your health, but it's also the fear that what it will cost and the long-term economic implications of getting sick or getting injured.
Yeah.
You know, because to be, I think, have our human rights actually realized, one of the key pieces is they must be universal and equitable. And I think that that's the major sort of issue that we have when addressing healthcare, is that it's not necessarily universal. The access isn't across the board for everyone in an equitable way. And some people have more than others, and that may be based on situation, usually on how much money you have, and maybe location, state by state, rural versus urban, all of those things. And that's not universal then.
We know we're talking about whole persons here, and the architects of the human rights documents that we rely on took a holistic approach. And it's, if you read the documents, you just see how, you know, one thing flows into another. You can't really address any of this. Healthcare is not something we can address in isolation of all these other surrounding important topics. So let's talk more in detail. The Human Rights Network in Montana is strongly advocating for human rights in general, but specifically in this time of the year, and with respect to elections and federal health care initiatives, you're pressing for a Medicaid expansion, and you've sponsored an initiative to expand Medicaid. And so why don't you start talking about that? And I don't know if there's a direct correlation to that effort with the work you do, but I suspect there is.
Yeah, there is.
So we can get those things together.
Yeah, so we have been working at the Montana Human Rights Network in coalition with a whole variety of community organizations as well as elected officials to advocate for the expansion of Medicaid in Montana. And that was an option that the state has always had. It's a Montana program that's existed for 40 years, and I think people feel pretty good about how it's gone. But with the passage of the Affordable Care Act, there was the opportunity to access additional federal funds that really opened us up to expanding Medicaid to cover 70,000 more Montanans is what really we're talking about population-wise. And we've basically attempted to advocate for that in a variety of ways. I think many folks will remember the Supreme Court sort of took up the issue of Affordable Care Act, and one of the pieces was that, okay, all of this is legal except for each state has the choice when it comes to expansion. Yeah. And our state chose not to during the legislative session last year. And we were very disappointed because it's really important to think about increasing and getting closer to that universality of healthcare access, and this was not that direction. So outside the legislative session and advocating for that, we said, we've got to take this to the voters. I think this is really important. I mean, 70,000 people in Montana.
That's a lot of people.
That's a lot of people. It's a lot of voters. So they should have a say in how they feel about this. So with this coalition of, we've got women's organizations, unions, rural hospitals, senior organizations, all really coming together, faith groups, and putting forward an initiative that would expand Medicaid to cover those 70,000 more people. The initiative does a few specific things. I'm happy to talk about what those are. And we'll be collecting signatures until the end of June. Those signatures will be turned in and go to the Secretary of State and thus qualify for the ballot, and then folks will vote in November.
Yeah. Well, before we leave the technicalities of an initiative, you know, we're one of the states that has this citizen initiative privilege and right in our Constitution. In this case, one of the caveats for any initiative is that the citizens directly cannot appropriate money.
Right.
So, in the event the initiative passes, the people are saying, yes, we want Medicaid expansion, but it doesn't happen overnight financially.
Right.
And backing up, you know, with Medicaid expansion, the federal government has guaranteed like 100% of the costs for several years.
First 3 years.
First 3 years. So the legislature will again play a critical role in determining the actual outcome of the Medicaid expansion. Well, aside, you know, we'll get back to the money question because that's hidden behind all of this, the debate over this subject. Right. How do you view Medicaid expansion and how it would affect your clientele?
It would affect our clientele hugely. Over half of our patients at Cooperative Health Center earn less than 100% of poverty. And because they earn less than 100% of poverty, they do not qualify for subsidies through the Affordable Care Act. They will qualify if we expand Medicaid. They will get health insurance, but most of our patients, the Affordable Care Act, as it's being implemented in Montana, it's not going to help them at all. And also the expansion of Medicaid, I think, is really important because we at community health centers nationwide, we provide a huge variety of services to everyone. We not only have doctors and mid-level providers, but we also have case managers and counselors and dentists and people to help you get your medications for free and others who really provide a patient-centered medical home for patients. And Medicaid actually reimburses us for all of that work. We get a cost-based reimbursement that includes the cost of all of those services for every visit, and that really helps people because beyond a doctor's visit, patients frequently need help maybe getting new housing or help getting access to substance abuse treatment or help buying their medications. They might not have the money to buy their medications, and we can provide all of that. I know there's talk about having the private insurance companies run a Medicaid-like system for low-income Montanans. But traditionally, private insurance companies only pay for the doctor visit. They don't pay for the wide array of services that community health centers and community mental health centers provide. And I think it would be doing a disservice for the providers and for the potential insured individuals.
Yeah. You mentioned mental health, which again is mentioned in these core documents. And mental health is getting a lot more attention these days, partly as a consequence of veterans returning from wars who are injured and have mental challenges. But then there's just pervasive mental health issues that have been sort of ignored or set aside for so long. There's been a stigma attached to mental health, and I think there still is. And you know, it didn't occur to me to ask you about, does Medicaid address mental health? You know, can you get Medicaid insurance or reimbursement for mental health treatment?
Yes.
It's part of the mix.
Yes.
Absolutely.
Yes.
And we're talking about estimated 5,000 veterans that are in this expansion population as well. So I think that's a really good sort of to mention who it impacts. And I mean, clearly lots of people need access to mental health services and other services offered, but I mean, 5,000 veterans are in this population of expansion. Similarly, about 5,000 senior citizens. So quite a few people that, I mean, we know. I mean, these are folks in our community when we're talking about those numbers. I would also mention that it's so funny because when we're talking about these government programs like Medicaid, where we have this great, you know, state program, it still relies on some interesting numbers from the federal government, like 100% of poverty.
Right.
And that always sort of cracks me up because we say, well, this would expand to 138%. Like, how can you have more than 100% of something? So it's a little bit funny. But I do think in real numbers, you know, this is people with $16,000 or under a year in income for a single person, or $27,000 for a family of three. This is not a lot of money. Folks are living on quite a small budget, and so very important vulnerable populations when we talk about those numbers.
Yeah.
Yeah.
And we know, I mean, we all know if you don't have a lot of money, we've all been there at some point, if we're not still there.
Yeah.
You have to make choices, and they're difficult choices, and you know, there's housing and food and transportation, and if you have a job, you got to get there, and public transportation in our environment is not readily available.
Yeah.
So we know people are choosing to not get primary care when they probably need it the most because they know it's going to cost them, and that means less of everything else.
Right.
So it does seem to be kind of an existential challenge.
Or accessing emergency room services, which is very, I mean, that's their last resort for folks, I think, a lot of times. And then we end up with people seeking really primary care situations in emergency rooms or bad emergency situations because things have been deferred in their health care. And that is costly to our hospitals, healthcare providers, to our rural hospitals particularly, who are really bearing a lot of burden of some of that lack of access, and thus also delayed seeking of health services because of the economic impact. And those costs get passed on to the rest of us. And so I think it's also important to know that I think, for example, Medicaid expansion and the initiative I-170, it is helpful for all of us economically too, because the impact of delaying seeking health coverage care or even having access to it, it's problematic for everyone across the board, for providers as well as for the rest of the folks who are receiving services.
Yeah, I'm glad you brought up the emergency room situation, because during the last legislative session, and it was a close call, I mean, they almost endorsed the expansion of Medicaid. There were a few votes there.
Right.
But during the hearings on that subject, you know, the major hospitals, provider groups, you know, they're making the case that, you know, this is the most expensive way to honor a right. I mean, they didn't put it in those terms.
Right.
But in a de facto sense, Americans do have a right to health care because the government will not permit an emergency room in a major hospital to to decline treatment. So I think people they get it. That, you know, if they really need to go to the doctor, they'll go to the emergency room and see what happens, and they won't have to pay an arm and a leg for it. But we're all learning that, well, we're all paying arms and legs for this.
Well, they will be charged.
This application.
They will be charged an arm and a leg, and be sent to collections if they don't pay it.
That's extremely important to know that.
Yeah.
It's not a free ride.
But they won't be denied.
On the gurney.
They will get care, but they will get
the bill.
A huge bill.
Yeah.
Do you deal with a lot of people who are faced with that after the fact burden? That
Yes, definitely.
would.
Yeah, we actually at Cooperative Health, every community health center is very unique. We all scramble and scrape together all the agreements that we can and all the ways that we can help our patients. And here in Helena at Cooperative Health Center, we have a great agreement with St. Pete's Hospital where if we refer our patients to the emergency room, one of our medical providers considers it an appropriate and necessary visit, the emergency room physicians will see it, they'll see them on the slide. So they will charge them based on their income.
Oh.
But only for those that we refer. This not
So they've been vetted as actually
we
needing
don't
emergency
refer people for primary care at the emergency room. But if they call and say, the right side of my body is, I can't feel the right side of my body, then we would say, you should go to the emergency room, and we make a note of that and work with the emergency room so that they can not be charged a lot of money if they don't have a lot of money, if they don't earn a lot of money.
Yeah. This is one way to illustrate that most people involved in the provision of health care and healthcare education really do want to help other people.
Yes.
The underlying ethos of human rights in general, but this one in particular is people aren't mentally, consciously seeking to hurt others or deny them access to what they need. However, in the world of political economy, I'm kind of circling back to the situation. Montana is one of about half of the states in the United States who, through legislation, through democratic processes, said no to the offer from the federal government to subsidize Medicaid expansion for the first 3 years. And the arguments I'm here recalling from the people who said no and won the argument in Montana was that, it sounds good. It sounds like we're not really paying for it for 3 years. The burden isn't going to fall on the state's taxpayers. It's falling on the nation as a whole. But then after all, we're all the same. We're all paying these taxes. So it was mostly a financial argument to deny the expansion of Medicaid, and I think it probably still is. However, in addition, there is another initiative now that's seeking signatures and may be on the ballot, which is diametrically opposed to the one you're talking about. I-170 is for Medicaid expansion. I-171, I think, would actually prohibit the state from actually implementing the Affordable Care Act and absolutely prevent the expansion of Medicaid. So we have, kind of a civil war in words on the ballot coming up.
I think there's two pieces. One, there is an individual who's running for office, Matthew Monforton, out of Bozeman area, who is proposed this opposition initiative in many ways. I think that that's a pretty small group of people who actually think we should totally change everything about how we implement healthcare in our state, because in a lot of ways that's exactly what happened. I mean, this has far-reaching implications for many programs that people are very comfortable with, aware of, benefiting from, used to, in addition to Medicaid. But I don't think that that is where the majority of population is. So we're mostly speaking to the majority of the population, because we've been here before in some of these conversations around what it means to expand our right to access to health care. We passed the Children's Healthcare Initiative expansion by initiative with 72% of the vote. And those things tell us that the people of Montana are very supportive of taking care of each other, having sort of a social fabric that's connected to take care of each other, and they're not necessarily opposed to those things. When we put the fear of raising taxes in front of people, I think it'll make a lot of people question. When I've been out collecting signatures and someone says to me, "Will this raise my taxes?" I say, I can't tell you what'll raise your taxes, but I can say that you are already paying for this. Montanans are already paying taxes as part of our federal tax system to cover the expansion, and now it's just happening in other states, and our money is going elsewhere.
So we're
not here.
exporting our dollars.
We're exporting it. The federal government covers 100% of this expansion for the first 3 years. By 2020, Montana would be responsible for only 10%. The initiative not only expands the population, but it also says that if that agreement was ever broken and the federal government said we will not pay 90% after 2020, then it's null and void. It goes away. So really, the burden that we might face in taxes is not increased. And we're probably just facing that burden in other ways by shifting care to emergency rooms, delaying care. And it's where we look at how our money is, where we spend those dollars. But I think that that's sort of been my answer to folks about that question. We're taking on the Matthew Bonforton's initiative legally as well, because not only do we think it's a violation of human rights to propose really denying people a lot of their access to health care, but it's also a constitutional problem. And we have some state legal issues with the initiative itself. So that is challenged currently in court and will continue to be.
So it's not a foregone conclusion, actually, that either initiative will actually be on the ballot. As likely as it is, we have to wait and see.
That's right.
If one or both actually are before us as voters and having to make that choice.
Yeah, and I think we're talking about a policy that has to do with a Montana-run program that has existed for 40 years. Medicaid is a Montana program with a Montana solution to making sure we cover 70,000 more people. It's not a political discussion for us. This is a bipartisan, nonpartisan conversation that we're having about something that's very important, our health. I think in a lot of ways, the other conversation that's happening on this opposition initiative is a political conversation using fear of national healthcare debate that has been going on for multiple years. And that, to me, is not fair to the people of Montana, to have a political discussion about, quite frankly, Obamacare, rather than a real discussion about a program that we can really help provide more health care to people in Montana.
And ironically, I think that most Americans and most Montanans think that everyone who's has a low income is on Medicaid already, and including former Representative Rehberg. He assumed that all poor Montanans were on Medicaid and could get access to health care. The truth is that in Montana and many states in the nation, only pregnant women, children, low-income children, and people with low incomes who have some severe disability, whether it's a mental health disability or blindness, they're the only ones who actually qualify for Medicaid in Montana. Most people who are living in poverty, if they're able-bodied, do not qualify at this point for Medicaid. So all the Medicaid expansion is proposing to do is to provide Medicaid health insurance to everyone with low incomes in Montana. And I think that most Montanans think that that's already happening.
With expansion, you can make just a little, really. It's not even that much, and be qualified. And
you don't have to be debilitated.
No, you don't. And also the thing is, it's interesting is, a lot of the folks that are in this gap, so we're talking about these people as in the gap, they also don't qualify for subsidies on the new healthcare exchange. And that's a real problem that wasn't supposed to exist, quite frankly.
Yeah.
When we went and took on healthcare reform in the US, the package meant that everyone had coverage in some way or had access to subsidies on the exchange or had access through their employer. I mean, there was some way that all people were going to have access to healthcare. When the Supreme Court said, okay, actually this piece is optional, we created a gap in the middle. And
at the bottom, really.
At the bottom, at the bottom, at the bottom middle. Yeah, the bottom.
The middle of the bottom.
Right?
Yeah.
But really, there are all these folks who, they can't even go on the exchange and get a subsidy to buy health care insurance if they had the money to, because this population really wasn't supposed to exist uncovered.
Yeah.
It's a real problem that we have people who are in the gap, and we're calling this group in a campaign we're doing called Montanans Denied. These are folks who are denied really because they can't access either option. And that's really problematic. It's very, very problematic. I don't know, I'll tell you the other things that the initiative does I think are really important besides this lever if the federal government never decides to at some point not cover the 90% in 2020 and beyond. It also expands the population eligibility requirements. It creates a reserve fund where this money that we accept from the federal government that's already being used by the states, where this money goes. And then it does one more piece, and that is it creates an advisory committee, really, that is made up of folks in the healthcare industry as well as those folks who are seeking services. And they will be looking at our current system in Montana, our current Montana programs, and advising the populace on that, the governor, the legislature. So there's an option there for review. And that, I think, is a key piece of having healthcare as a human right, is that there is a review process to make sure we're following through with these pieces. And there are folks who are interested in reforms. Yeah. And packaging those together didn't necessarily make sense right now, but it does make sense for us to look at that and make sure it's functioning well. I didn't know that the advisory committee was something that people would really be interested in, but people are really interested in that idea. So it's another piece of the initiative.
Yeah.
And community health centers have always been run by at least a board of at least 51% users of our clinics. And so that's a great model to use for the Medicaid expansion advisory board.
Absolutely.
Yeah. Well, in a way, what I'm hearing is interesting in that it's a combination of overarching principles. I mean, we have human rights because we're human beings, and we are entitled to these rights through our government. It's a democracy, and that's how our rights are realized, through the exercise of self-government. And yet, at the same time, it seems important that when you get down to actually implementing rights such as health care, operating within a state boundary makes a lot of sense. I mean, it's a much more manageable sized community of self-determined people. So it's an interesting overlay of universality, national policy, and then kind of honoring the federalist principle that states have rights unto themselves, collectivities unto themselves, and they're better able to figure out the nuts and bolts of providing for such rights, you know, at a certain scale. And I'm kind of leading to a question of sorts, in addition to the basic question. Let's pretend just for a moment that Medicaid expansion does not happen. It's not happening now. It probably will, but if it doesn't, what's the next best way to ensure the human rights that you're advocating for and that you're actually meeting, you know, day to day? Have you thought about Plan B, or do you not want to go there at this time?
We're doing Plan B right now.
Yeah.
I mean,
we're living Plan B.
We're living Plan B. Yeah.
That's a great point.
You know, we're providing primary care to everyone regardless of their ability to pay. We have at Cooperative Health, we have our main clinic, a clinic at God's Love for homeless individuals, and also a clinic in Lincoln. And then after the level of primary care, if somebody needs surgery or anything, any specialty care, we are cobbling together solutions for each individual, which is not efficient and not necessarily helpful to the individual or our entire community. I mean, I think that our community would be better served if everyone could get the health care that they need and be as healthy as possible. Because then everyone could work, everyone could be just a more vibrant part of the community.
Yeah.
Absolutely.
So Plan B, the one we're living now, I mean, there's a lot of evidence that this is really the most expensive, dysfunctional way to achieve a basic human need.
Yeah.
And the experience that we witness in many other democratic countries proves that. I mean, there are other ways to do this that work at far less cost, with far more coverage, far more insurance of this basic human right.
Right.
We only have a couple minutes left, and I want to give you the opportunity to make a pitch for your organization, for the initiative, before we close out.
Absolutely. Well, I would encourage people to, inform yourself about healthcare and about how it's working, and also to get involved with the initiative, the Healthy Montana Plan, I-170. You can do that through a variety of entities, and folks can contact the Montana Human Rights Network. They can become a member and supporter and signature gatherer and activist, or people can really also just access information and education. We have a variety of partners, and I think going to that entity and group that you identify with, so may that be union, may that be someone you know at a rural hospital, maybe a women's organization, those are great entry points as well to finding out information and engaging. We absolutely need help to gather enough signatures and do the education, as well as to continue our pressure on our legislators that they too can make the choice to go ahead and expand now by coming together as a group. So that's both in process. We have to collect signatures of 5% of the electorate and 5% of 34 House districts, which is about 24,000 plus signatures. And that takes, quite frankly, a lot of volunteers. This is community effort, and we're basing all of this work on a shoestring budget, and we're up against, quite frankly, 2 billionaires from Oklahoma. There's a lot of external money from well-known entities that are being dumped into our state to oppose this for political reasons. And we think that when we talk about it for a values, moral conversation, people are excited and they want to sign and they want to do this and they want to make sure more people have access to healthcare and healthy life. So that would be my full pitch, Stephen.
Okay.
So community health centers have been a great Band-Aid to get America to where we're still trying to go, with everyone being covered by health insurance and therefore have access to health care. I hope that someday in the near future, all healthcare providers will be like a community health center, where all patients can have access to a physician, a case manager, a counselor, a dentist, outreach workers to help them live healthy lives. And we'll forget that we once had these special places where uninsured people could go, because everyone will be insured and everyone will have the same access to the same level of health care in this country.
We're going to make that the last word.
Yeah.
So Kate and Rachel, thank you very much for being here. Greatly respect the work you're doing, and I'm sure I'm not alone in that.
Thank you so much.
In 2008, before the advent of the Federal Affordable Health Care Act, the Lewis and Clark County Board of Health assembled a universal health care task force. This voluntary effort yielded an official resolution recognizing health and health care as basic human rights and outlined an action plan for its implementation. The county health administrator, Melanie Reynolds, recalls both the challenge and the promise of this endeavor.
That resolution was in December of 2008, and it was access to universal health care. And basically that resolution adopted by the Board of Health said that there is a human right to health and health care, along with a government obligation to guarantee universal access to health care. It was a far-reaching and bold statement. There's some interesting findings that came from the assessment. First of all, there were 4 areas that came out from the community focus groups. One was, yes, there is access issues. We are having trouble getting access. And one of the biggest access issues was costs. We also, there was a perception in these focus groups that there was not an availability of health care. There had been a lot of turnover of primary care physicians. There was concern that there weren't enough primary care physicians. There was a feeling of concerns around quality of health care. And that was mostly, as when it was teased out, was more about wait times, feeling like there's been wasteful spending. So much of the money was going toward administration and not toward direct health care. And there was feelings of feeling as second-class citizens because they were poor or could not afford health care. The community survey, there was a very interesting question that we asked, and we asked the respondents to say, do you think health care is a human right? Do you think it's a basic right? And 72% of the people that completed the survey said that there was. You know, I think it's just so important and so compelling. Our national organization, the National Association of City County Health Officials, has also come out with a resolution to promote health equity. And that social justice is a core value of public health. And the birth of public health is around social justice. And there is a fundamental need for health care. And how are we going to go about that? So although our health department, probably more than maybe other health departments in Montana, have looked at this issue from a human rights perspective, we're not unlike the rest of public health that sees this as an extremely important issue.
The World Health Organization Charter holds that improving global health requires a secure foundation in food security, education, shelter, stable ecosystems, sustainable resources, and social justice. Healthcare is clearly a vital component in a larger holistic construct. In light of this large frame of reference, State Senator Dave Lewis shares some of his frustration and skepticism about approaching healthcare as a human right.
You know, it's an interesting question. I guess the first thing that comes to my mind is, who are we talking about that doesn't have health care? I mean, elderly people have health care, like myself, under Medicare. Employed people generally have health care from employers. Children have health care, lower income children through our CHIP program, disabled people through Medicaid. And so we're talking basically, I think, about unemployed people of working age. And the question is whether or not they should be able to count on health care provided by the taxpayers as a basic right. And I guess the second thought that comes to me is, well, then why stop there? Why not housing? Why not having an automobile? Why not almost anything else? I mean, why aren't people required to go out if you're able-bodied and go to work and take care of your basic needs? And I think, again, food, shelter, health care are basic needs. So it gets down to who should pay, who's going to be covered. And I guess my answer is no, I don't think it should be considered to be a basic right provided by the taxpayers. No, I think that's really, again, interesting. I think that assumes that the general public has to pay for benefits for people who are not providing those benefits to themselves. And I just find that very difficult. I think there's a basic responsibility for an adult, an able-bodied adult, to go out and go to work and provide for the basic needs, rather than requiring society to provide those basic needs. And so I think that's probably the basis of a major philosophical difference between the political parties and between right and left in the United States and nationally, is to how far that social compact goes. What is the requirement for the general taxpayer to pay for benefits for the general public? And not an easy question. I guess I come down on the side of personal responsibility.
Nancy Augenis is a recently retired naturopath with broad experience in providing health care services and a deep regard for both the primacy of individual responsibility and the integration of traditional and modern approaches to health.
You have to define what health care is. And I think that health care, we don't currently have a healthcare system. We have a whole bunch of parts operating independently, often with high intention. But without a system, I don't know, it's like if you're banging your shin into the coffee table every time you get up, is the problem the bruise, or is the problem banging your shin into the coffee table every time you get up? I've been thinking a lot about obesity, and I am increasingly convinced that the cause of obesity is insulin resistance. And that if we addressed insulin resistance, we would go a long ways. But if the basic right of health care is always addressing the symptoms and is done in a non-systematic way, who wants a right to it?
Right. And if we're not dealing with the underlying root cause of whatever the issue is, we're treating symptoms, we're not solving problems, and we're not empowering people to believe that healthcare is within their own ability to provide for themselves.
And if healthcare is a basic human right, means that anybody can have any procedure they want anytime, then we have to ration care. We can't afford that. And the best care is often the least care. If the most expensive care is the best care, then rationing is the only answer. The other thing I really want to say in thinking about this is that healthcare is clean water. Healthcare is nourishing food. And in that, I think clean water and nourishing food are a basic human right. But when you talk about healthcare, that isn't often what's even discussed. Yesterday at Hometown, they talked about raising another $8 million for the cancer treatment facilities at St. Peter's. And I want to know when the capital expenses of naturopathic medicine are going to be raised publicly like that. And I thought of when the director of the Cancer Treatment Center was asked the question, what is the cause of the increase in cancer cases? She answered environmental things. She answered pesticides. She didn't answer lack of a nuclear linear accelerator. She didn't answer lack of a PET scanner. And so the basic healthcare need isn't those things really, although I appreciate that they're doing it. I'm grateful. I'm sure they'll help people. But if we don't get back to addressing what that cause is, which might be educating third graders, we might do a lot less cancer treatment in our community than we're going to do simply by providing more expensive treatment. It just doesn't make sense to me. I just retired in December, and I've been doing this all my adult life, and I left there yesterday feeling kind of sad about, wow, we're still here. This is still what's happening.
Right, we're still sort of having conversation about how to distribute care, distribute medicine, distribute treatment to secondary and tertiary issues when we're not dealing with the fact that food and water and exercise and good health in that way is the underlying root cause of good health 30 years from now.
Yeah. So yeah, everybody should have access. Every mother should be able to take her child to a physician if her child is sick. And I am more concerned about access than I even am about more egalitarian treatment of naturopathic doctors. I really care that people have access. And access should be a basic human right. What healthcare is, however, is a much bigger question.
T.R. Reid is a respected journalist who has spoken to Montana audiences and written a book entitled The Healing of America. The following excerpt from a televised interview provides a glimpse of Mr. Reid's personal views on healthcare in a global setting.
I'm Shirley Hoekstra, and my guest today is T.R. Reid, a media correspondent and author of The Healing of America, a global quest for better, cheaper, and fairer healthcare, which he wrote traveling around the world to compare national healthcare systems. Welcome, T.R.
Shirley, great to be here.
You know, when you traveled around the world, you saw that most other countries actually guarantee healthcare for their citizens, and the U.S. does not.
Yeah, what a striking difference. All the other industrialized democracies, I mean, you know, countries like us, rich, free market, industrialized, advanced democracies, they all provide health care for everybody. It's high quality care, and guess what? They spend half as much as we do. So that's what I did. I went around the world to see if I could figure out how they do it.
Now, they're doing it probably by keeping salaries for doctors and hospitals in a different kind of ratio, aren't they?
Yeah, that's absolutely true. American doctors make much more than doctors anywhere else. American hospitals are the highest priced hospitals in the world. And this all goes together. You know, I said they cover everybody and they spend less. It's not a coincidence. If you have everybody in the system, it turns out that's a cheaper way to run healthcare than this kind of erratic coverage that we have. You know, in America, some people get the finest care in the world. That's why Arab sheiks fly to Mayo Clinic. But a lot of people are kind of left out the door. That doesn't happen in other countries. The other countries have a basic floor of care that everybody gets. And if you arrange things that way, it just saves a lot of money.
So this is really a moral question, though, because for the people who are getting health care in the United States, most of people think that there's no problem. I'm getting good care. Why would I want a slightly lower convenience or standard of care in order for everyone to have it, because it doesn't affect me? And you are really making an argument that this is a moral question. You first have to say, should everyone have health care?
Yeah, you absolutely got my book. Well, the main thing I learned going around the world was when you design a country's healthcare system, look, it involves medical decisions, it involves economic decisions, obviously a political question. Primarily, though, it's a moral question. Do you want to be a society where everybody who's sick can have access to a doctor? And if you decide to be that society, hey, you can do it. There's a mechanism, and all the other countries have done it. And one of the mysteries for me in the book, I figured out how the other countries do it, I think. I figured out why the other countries do it, but I still can't figure out why the world's richest country doesn't provide coverage for everybody.
Well, let's explore that some, because we consider ourselves a moral country. We consider ourselves almost a faith-based country. We've heard that in the rhetoric of our politicians.
Sure.
So why haven't we been asking this moral question as the first question instead of how much is this going to cost? That seems to be the primary question in the United States all the time.
Yeah, and who's going to win and who's going to lose, and insurance company reimbursement rates and all that stuff. I argue in my book, every time we get to this issue, we lose the basic moral question amid all the mechanics of insurance company payments and hospital payments and the like. Why is it? You know, I can't figure it out. So here, I'll tell you my theories.
Okay.
One theory is, hey, we're a democratic country. We designed the system. We want the system we've got, where a lot of people get great care and tens of millions don't get it. Is that right? Are we that kind of country? I think no.
Okay.
So I finally conclude Americans don't know how cruel our system is.
It's time for our celebrated pop quiz. But there aren't any questions this time. What to ask? There aren't any cut and dried questions or answers about health care as a human right. So I'll leave you with two things to think about. First, why is it that the United States is so far behind other advanced industrialized countries in providing basic health care to all of its citizens? And secondly, the United States is not a party to the International Covenant on Economic, Social, and Cultural Rights. Why is that?
When I think of human rights, I think of how every human being is made in the image and likeness of God, and therefore we all deserve an intrinsic right to dignity and respect. And I also think about how there are so many people who do not have our basic needs of food, shelter, water, and good relationships. And it's our job and our duty to help provide those things. And that means feeding the hungry, giving drink to the thirsty, clothing the naked, visiting the imprisoned, and other spiritual and corporal works of mercy like that. Because there are so many people out there who don't have basic needs. And because we're all human and we deserve dignity, they deserve those things to make themselves dignified as well. And we're also social creatures, and we're meant to be in relationship. So if we don't have safe, healthy, happy relationships, that we aren't being treated like the humans we need to be.
Thanks for watching.